The nursing assessment of patients with musculoskeletal dysfunction focuses on understanding both history and physical findings. The goal is to see how the disorder affects the patient's life and function. As people age, bones begin to lose mass gradually, starting around the age of 30. This can result in fragile bones, vertebral collapse, fractures of the hip, wrist, or spine, and a gradual loss of height. Posture changes are common, with patients developing kyphosis or a rounding of the spine and increased flexion of the hips and knees. Flexibility is reduced, and many patients experience back pain or osteoporosis. Muscles also change with age. Collagen increases, muscles become fibrotic, and they atrophy or shrink in size. Strength declines, tendons become less elastic, and this can lead to weakness, fatigue, stumbling, and falls. Reaction times are slower, tone is diminished, and endurance is reduced. Joints and ligaments are also affected by aging. Cartilage deteriorates and intervertebral discs thin, which causes stiffness, reduced flexibility, and pain during activity. Range of motion is limited. Ligaments become lax and weaker, producing joint abnormalities, swelling, crepitus, and pain with motion. These changes are often linked with degenerative joint disease, such as osteoarthritis. When gathering a health history, it is important to remember that musculoskeletal conditions may be stable or progressive. They may have quiet symptom-free periods followed by flare-ups. History taking should include the onset, character, severity, location, duration, and frequency of symptoms. Ask about aggravating and relieving factors, associated complaints, family history, and whether symptoms are progressing or improving. Pain is one of the most common symptoms. Bone pain is usually a dull, deep ache that is not related to movement and may interfere with sleep. Muscle pain is often described as soreness or cramps. Fracture pain is sharp and piercing and is relieved when the affected area is immobilized. Joint pain is usually felt in or around the joint and tends to worsen with movement. Steadily increasing pain may indicate infection, tumor, or vascular complications. Pain that radiates into an extremity may point to nerve root involvement. The time of day also provides important clues. Pain from inflammatory conditions is often worse in the morning, tendinitis eases as the day goes on, and osteoarthritis pain typically worsens later in the day. Altered sensations are another common finding. Patients may describe burning, tingling, or numbness. These are often caused by nerve pressure or impaired circulation. It is important to compare the affected extremity with the unaffected one. When taking a complete history, include occupation, activity level, alcohol and tobacco use, nutrition, other medical conditions, and any history of falls or trauma. The Fracture Risk Assessment Tool, also known as FRAX, is an online tool created by the World Health Organization. It estimates a patient's 10-year risk of fracture. It takes into account age, gender, body mass index, fracture history, smoking, corticosteroid use, rheumatoid arthritis, alcohol use, and other secondary causes of osteoporosis. Bone mineral density can also be entered if available, though it is not required. Patients over 50, postmenopausal women, and those with low bone density or risk factors are candidates for assessment. Some musculoskeletal conditions are genetic. Autosomal dominant conditions include achondroplasia, Nail-Patella syndrome, osteogenesis imperfecta, polydactyly, and van der Waals syndrome. Autosomal recessive conditions include Tay-Sachs disease. Forms of muscular dystrophy include Duchenne, Becker, congenital, distal, Emery-Dreifuss, facioscapulohumeral, and limb girdle. Other genetic conditions that impact the musculoskeletal system include amyotrophic lateral sclerosis, Ehlers-Danlos syndrome, Marfan syndrome, spina bifida, and Stickler syndrome. When assessing genetics, take a 3-generation family history, note disease-specific skeletal findings such as scoliosis or abnormal stature, and watch for signs like unexplained fractures, hypermobility, or changes in muscle tone. Physical examination ranges from functional evaluation of daily activities to more focused maneuvers. Nurses focus on posture, gait, bone integrity, joint function, muscle strength, skin, and neurovascular status. Normal posture includes a thoracic curve that is convex and cervical and lumbar curves that are concave. Abnormalities include kyphosis, lordosis, and scoliosis. Causes may include degenerative disease, fractures, obesity, or neuromuscular conditions. Inspect for symmetry of shoulders and hips, and note uneven waistlines or scapula prominence in scoliosis. Gait should be smooth and rhythmic. Limping may be due to painful weight bearing, limb length differences, or limited joint motion. Certain neurologic conditions cause distinctive gait patterns, such as the shuffling gait of Parkinson's disease, the steppage gait seen in lower motor neuron disease, or spastic gait after a stroke. Bone integrity is checked by comparing extremities for alignment, deformity, and length. Findings in fractures include abnormal angulation, abnormal movement, and crepitus. Always check circulation and sensation, capillary refill, color, temperature, and pulses distal to the injury. Joint function is assessed by noting range of motion, deformity, tenderness, and nodules. Range of motion is tested actively and passively. Limited motion can come from deformity, arthritis, or contractures. If a joint is swollen and landmarks are obscured, an effusion may be present. The knee is a common site. Signs of inflammation may require consultation with a specialist. Palpation of joints provides more detail. Normal joints move smoothly. Snapping or cracking may mean ligaments are slipping over bone, while crepitus suggests arthritis. Rheumatoid nodules are soft and located along tendons. Gout nodules are hard and contain uric acid crystals. Osteoarthritis nodules are hard, painless, and result from bony overgrowth. Muscle assessment includes strength, coordination, size, and tone. Weakness may indicate conditions such as electrolyte imbalance, myasthenia gravis, or muscular dystrophy. Muscle strength can be tested with resistance, such as having the patient flex the arm against your pressure. Measure limb circumference to monitor for atrophy, swelling, or hypertrophy. Differences greater than 1 centimeter are significant. Skin inspection is part of the musculoskeletal exam. Look for bruises, cuts, swelling, and color changes. Palpation reveals areas that are warmer, suggesting inflammation, or cooler, suggesting impaired perfusion. Neurovascular assessment is especially important in patients with fractures. Always evaluate circulation, motion, and sensation. A key condition to monitor is compartment syndrome, where increased pressure inside a muscle compartment reduces circulation. Without intervention, permanent damage can occur in as little as 6 hours. In summary, musculoskeletal assessment blends history, physical examination, and functional evaluation. As nurses, recognizing early changes allows us to prevent complications, guide care, and promote independence for our patients.